Good morning. I'm Salvador Hernandez, and I'm a first-year cardiology fellow at Kaiser Permanente in San Francisco. And we have the pleasure of having Dr. Dirk Woo Park from the Division of Cardiology at the Asian Medical Center for the University of Ulsan College of Medicine in Seoul, Korea. And he's going to be talking to us today about the ADAPT-TAVR trial.
So our ADAPT-TAVR trial is rationale is the leaflet thrombosis after TAVR is absolutely one of the major problem in daily TAVR practice.
Yeah.
So what is known and what is unknown. On the basis of a prior observational study, we know oral anticoagulant reduce the leaflet thrombosis, but we don't know the real causal association of leaflet thrombosis and cerebral thromboembolism. Also, we don't know oral anticoagulation can reduce leaflet thrombosis related to cerebral thromboembolism. So, our ADAPT-TAVR trial primary objective is investigate the effect of edoxaban compared to dual antiplatelet therapy, aspirin and clopidogrel, for prevention of leaflet thrombosis and accompanying potential risk of cerebral thromboembolism and neurocognitive dysfunction in patients without oral anticoagulation indication after TAVR. And the secondary objective is to determine causal relationship of leaflet thrombosis with the cerebral thromboembolism and neurological neurocognitive dysfunction. So our study is open label design, and we are targeting 220 patients without no indication of oral anticoagulation like atrial fibrillation. We randomization 1-to-1 ratio edoxaban versus dual antiplatelet therapy, aspirin plus clopidogrel. The primary endpoint is leaflet thrombosis, 4-dimensional cardiac CT at 6 months follow-up, and the key secondary endpoint, serial brain MRI at baseline and 6 months, and the neurological neurocognitive function test at baseline and 6 months. We also assess the echocardiographic parameter and clinical outcome. So, and the baseline characteristics at age is 80-year-old in both group. STS score is 30.3 in both group. And overall, the baseline characteristics was well matched. In baseline characteristic, balloon expandable stent used approximately 90%, remaining 10% treated with the self-expandable stent. So, and we will present the primary endpoint result and tomorrow. So, and the 4-dimensional primary endpoint, the leaflet thrombosis in ITT population at 6 months cardiac CT, the edoxaban group 9.8%, ADAPT group 18.4%, risk difference and 8.5%, risk ratio is 0.53, and p-value was 0.076 in the borderline significant. And the per protocol population and event leaflet thrombosis 9.1% in edoxaban group. ADAPT group is 19.1%, and the p-value was 0.047. In PP population, we achieved the statistical significance. And the key secondary endpoint is MRI finding, and we initially guessed if you reduce the oral anticoagulant, edoxaban can reduce the leaflet thrombosis, could be associated reduction of a brain MRI region, also neurocognitive the measurement at the function test. And very interestingly, presence of a new cerebral region on serial MRI and 25.0% in edoxaban group, and the depth group is 20.2%, absolutely no difference at all. Also, median number of total new region and the median volume of total new region, absolutely no difference at all between two groups. And another finding is a neurological and neurocognitive endpoint, and worsening of a NIS scale, absolutely no difference in between group, and the worsening of a modified Rankin scale is absolutely no different. Also, and the key finding is a neurocognitive function, the measure the Montreal cognitive assessment, absolutely no difference at all between two groups. Also, key finding, we try to define association of a severity of a lip thrombosis number and the width and the extent of a new region on brain MRI. We did not find any statistical significant association lip thrombosis severity and the brain MRI new region. There is no association. So another key finding is a lip thrombosis severity with the declining of a neurological assessment and the NIS score, modified Rankin score, and the MoCA neurocognitive function. We did not find any significant association. And the clinical outcome, just owing to the limited number of patients, we did not find any relevant difference in terms of efficacy outcome, death, stroke, myocardial infarction, also systemic thromboembolism, absolutely no difference. Also safety outcome, overall bleeding event comparable in between two groups, also major bleeding event, also similar in between two groups. Our trial conclusion and the primary endpoint of lip thrombosis on 6 months cardiac scan was less frequent, 8.5% difference, and the risk ratio of 0.53 with edoxaban therapy compared to the dual antiplatelet therapy. However, it did not reach statistical significance. And the instance of a new cerebral thromboembolism on brain MRI and the development of a neurological or neurocognitive dysfunction were not different between two groups. Lastly, there was no difference, no association between lip thrombosis and the temporal related change of a new cerebral thromboembolic region and the neurological endpoint. That is our trial conclusion.
Thank you so much for this information. This is definitely really valuable for all of our taking care of our patients. Dr. Park, thank you so much for the information, and we look forward to seeing you tomorrow.
Okay, thank you. Thank you. Bye-bye.